Good morning. Today's journal club presentation is Ketorolac versus methylprednisolone injection for subacromial impingement syndrome. My name is Anusha Lekshminarayanan, and I am the Sports Medicine Fellow with the Department of Rehabilitation Medicine at Montefiore Medical Center in Bronx, New York. I have no disclosures. The outline of my presentation is as follows. A brief discussion on the pathophysiology and management of subacromial impingement syndrome, followed by a review of the aim, methods, results, and limitations and conclusions of the journal article, and finally, the take-home points. Patients with subacromial impingement syndrome present with moderate to severe aching pain in the superolateral shoulder, worsened by overhead activity, lifting, and resting on the affected shoulder. The pain is felt in the upper third of the lateral arm by most patients. On physical exam, apart from the localized tenderness felt inferior to the acromion, Neers, Hawkins, Yoakum, and painful arc tests may be positive. This picture demonstrates the subacromial subdeltoid bursa as a red inflamed area between the acromion and the supraspinatus tendon. Extrinsic contributory factors of subacromial impingement syndrome include a curved and hooked acromion, as noted in the upper right corner of the slide as type 2 and type 3. Incompletely ossified acromion, known as os acromial, is also implicated. Dysfunction of the supraspinatus muscle and tendon can lead to decreased acromiohumeral interval less than 7 millimeters, with the typical range between 7 and 14 millimeters. Sprain of the ligaments in the proximity of the subacromial bursa, including the acromioclavicular and coracoclavicular ligaments, and scapular dyskinesia have also been noted in these patients. Intrinsic contributory factors include supraspinatus injury as a result of direct trauma, indirect trauma, or repetitive overuse injury, as seen in athletes who are swimmers, pitchers, tennis players, to name a few. Concomitant presentation of subacromial impingement syndrome includes the following: rotator cuff tendinopathy with or without tearing, which could present in the form of positive drop arm test, especially in complete tears; adhesive capsulitis with limitation of range of motion, especially external rotation; polymyalgia rheumatica with stiffness and proximal upper and lower limb weakness; rheumatoid arthritis with morning stiffness for more than an hour; subcoracoid subscapularis impingement. During exam, you may find pain during flexion, adduction, and internal rotation in these cases; prior shoulder dislocation and labral injury, which may present with positive O'Brien's and apprehension signs; and finally, honorary rotator cuff tendon biceps can have tendinopathy with positive Speeds and Yergesen tests. Dr. Charles Neer described a 3-grade spectrum for subacromial impingement syndrome. Grade 1 includes edema and hemorrhage and is seen in patients aged less than 25 years. Grade 2 includes fibrosis and tendinitis and is noted in the age group 25 to 40 years. And grade 3 includes rotator cuff tear, biceps tendon rupture, and bony changes, and is seen above 40 years. The diagnosis of subacromial impingement syndrome is made on the basis of history, physical exam, and ultrasound evaluation in clinic, especially dynamic ultrasound evaluation. Imaging modalities that we can use include radiographs, including the true anteroposterior view, 30-degree caudal tilt view, and supraspinatus outlet view or scapular Y view to evaluate the anatomy. And MRI can help confirm the anatomical variations and evaluate for tendon and labral injury. On the right, you can see a picture of a retracted supraspinatus tendon. The management of these patients starts by pain control using a short course of oral non-steroidal anti-inflammatory medications, if not contraindicated. Topical NSAIDs and acetaminophen can be used. Home exercises, avoidance of aggravating movements, and physical therapy to restore the range of motion and scapular stabilization are recommended. If the patient fails to respond to 6 weeks of conservative treatment, we typically provide ultrasound-guided glucocorticoid lidocaine injections to help with pain control and to help them tolerate therapy better. Some providers give up to 3 injections within 16 weeks. Ketorolac lidocaine injection has also been used by some providers to avoid the side effects of corticosteroids, and some providers have also used it for intra-articular injections of the shoulder, hip, and knee joints. If the patient fails to respond to conservative management over the period of 3 to 6 months, then orthopedic referral is recommended for arthroscopic subacromial decompression, and additionally, acromioplasty and or rotator cuff repair can be considered. Now, in terms of the choice of medication for subacromial subdeltoid bursa injections, steroids are contraindicated in uncontrolled diabetes, and Ketorolac could play a role in these patients. FDA issued black box warnings for Ketorolac in patients with existing atherosclerotic cardiovascular disease, upper gastrointestinal bleeding, and chronic kidney disease. We will be reviewing the journal article, Outcomes of Ketorolac versus Depomedrol Infiltrations for Subacromial Impingement Syndrome. This was a randomized controlled trial conducted by a team of orthopedic surgeons, including Dr. Goel and team. This was conducted at a level 1 trauma center in India and published in Musculoskeletal Surgery Journal. The authors wanted to compare the short-term outcomes of Ketorolac versus steroid injection into the subacromial bursa. Participants were recruited between May 2018 and January 2019 and divided into 2 groups of 35 participants, with group 1 receiving Ketorolac 60 milligrams and 5 ml of 2% lidocaine, and group 2 receiving methylprednisolone 40 milligrams and 5 ml of 2% lidocaine. Participants who were included in the study were included after they provided signed informed consent and based on clinical findings. Radiographs of the shoulder should be without a traumatic or osteoarthritic etiology. If fracture or arthritis, rotator cuff tear, prior allergic reaction, and uncontrolled diabetes were noted. Participants were excluded. Pregnant and lactating women were excluded, and participants with greater than 50% loss of range of motion of the shoulder were excluded. This flow diagram demonstrates how the authors assessed 86 participants for eligibility and excluded 16 due to a diagnosis of adhesive capsulitis, rotator cuff arthropathy, glenohumeral arthritis, and withdrawn consent. One participant from group 1 and 2 participants from group 2 dropped out of the study. The authors used a landmark-guided posterolateral to anterior approach for the injection. And post-injection rehabilitation protocol included range of motion exercises of the shoulder, posterior capsule stretching, and rotator cuff muscle strengthening. Participants were followed up in 4 weeks, and 2 patients from group 1 and 1 patient from group 2 were provided repeat injections at 4 weeks for residual pain. The authors used 3 outcome measures: visual analog scale for pain with a score difference of 2 and standard deviation of 2 reaching significance, shoulder pain and disability index with a score difference of 15 and a standard deviation of 15 reaching significance, and range of motion of the shoulder, including flexion, abduction, internal, and external rotation. The outcome measures were assessed before the injection, 1 month after the injection, and 3 months after the injection. SPSS software and sample t-test were used for analysis. Visual analog scale is something very similar to this. The authors did not include a picture of the specific analog scale they used, but this is just a sample. And this is how the shoulder pain and disability index looks, with 0 indicating no pain or no difficulty, and 10 indicating the worst pain imaginable and so difficult that they required help. Range of motion assessment was done in the sitting position with the trunk stabilized, and the results were classified as 0 to 4, with 0 being full range of motion and 4 being the subject being unable to move the hand behind the trunk. 1 was the subject was able to reach the opposite scapula, but not quite. So there was a lag of about 6 to 15 centimeters from the hand to the opposite scapula. 2 was when the hand reached the opposite iliac crest, and 3 was when the hand reached the buttock. So on review of the demographic profile, the mean age, gender profile, duration of symptoms, and right-left side involvement were similar in both groups. And as noted in table 2 on the right, there were no statistically significant differences noted in the visual analog scale, shoulder pain and disability index, and range of motion, inflection, abduction, internal and external rotation. There were some limitations of the study, which included that the diagnosis was made clinically, no imaging guidance was used for the injections, and the authors noted that no radiological improvements were noted after the administration of the injection. In conclusion, Ketorolac was as effective as corticosteroids when used for subacromial bursa injections. So our take-home points are Ketorolac injection can be an effective alternative to corticosteroid injections of the subacromial subdeltoid bursa. The dose recommended in the study was 60 milligrams, but 30 milligram dose has also been used with equal efficacy. Future studies could explore use of ketorolac in other bursae. At this time, there is no conclusive evidence for use of alternative NSAIDs, including tenoxicam and lornoxicam, for injections of the subacromial subdeltoid bursa. These are my references. I would like to thank you, the viewer, for attending this presentation, and AMSSM for this opportunity. I would also like to acknowledge the guidance provided by my program director, Dr. Driggs, and my attendings, Dr. Priya Patel and Dr. Eugene Palatulan. Thank you.
All right, good job, Anusha. Anyone has comments, questions, concerns?
Great job, Anusha. I guess I was going back to the article. So it was they didn't specify if it was one injector or if there were multiple injectors, correct?
That is right.
So I feel like I would see that as a limitation as well, just because it's hard to tell, especially if you're using landmark guidance, if you're accurately getting it into that subacromial bursal space every time.
Right.
Yeah, this was an excellent journal article, Anusha. Thanks for putting this in the spotlight. Certainly, you know, because in our practices, you know, in sports medicine, we certainly use a lot of cortisone injections. And so having a different injected medication, you know, can definitely be a good thing. Certainly everything that we give to our patients, you know, will have its own side effects as well. So it's definitely something to note as well.
Right.
And the one thing I definitely was thinking of based on the studies, they do a 1 month and 3 months, right? And so
Right.
certainly would have loved to see also, you know, longer, how it is, you know, long term, the differences between ketorolac and corticosteroid. So that's something certainly, hopefully somebody's working on in the pipeline.
Yes, that would be interesting. And I also was curious to know if a person is indicated for surgery, but they're in severe pain, and the surgery were to happen in the next 2 months or 6 weeks, and we wanted to help the patient. We wouldn't be able to do a steroid injection, but would we be able to do a ketorolac injection in those cases? That's something that I was also thinking about. What are your thoughts on that?
That's a great point. I think that would be probably surgeon specific, but that's a great point to definitely ask if any surgeon you're working with, if that's a possibility.
Okay.
Yeah, would love to hear from a surgical perspective on that for sure. And also, like, I do remember something back few AMSSM conferences ago when I think Dr. Motner and group were talking about ketorolac injection also for the knee in comparison to cortisone. And I think there's definitely a lot of data for the knee as well that's out there. So that's something to also keep in mind, because, you know, this is certainly, you know, something to keep in mind for the shoulder, but, you know, for the knee, there's definitely more data out there now.
Okay.
Yeah, those are all good points. I think if we think about our, I guess, tradition and our patient population and the, you know, the way we practice, where would, you know, and getting I don't want to say stakeholder buy-in, but you know, the people that source stuff for us, where is it that we're more likely to use Ketorolac? Those patients that come that we get with the hemoglobin A1Cs that
Mhm.
are a little scary,
Right.
and we're determining exactly what we're going to do. We pride ourselves on the fact that maybe using ultrasound means that you're going to be more accurate. You might have less of that systemic absorption, but um you can't guarantee that. So Ketorolac may be useful in that if we looking at our practice.
Right.
Based on their injection protocol here, what was curious to me is how it kind of departs from the way I think that I practice, and probably for you guys as well, where after 4 weeks, if someone still has symptoms, they were willing to give them another injection,
Right.
which is not typically something that um, I would do. So I don't know, how much that would have affected the results, and if that
Okay.
is, if that's something that we would want to encourage or adopt in our own practice. For me, I'm not really sure about that aspect in terms of giving injections so frequently. But I don't know what you guys think.
Yeah, I agree. I mean, I usually wait about 3 months between steroid injections specifically. I haven't been doing ketorolac injections, so I'm curious if we could repeat that earlier than 3 months.
And there were some studies where they mentioned that up to 3 injections were provided within 16 weeks by different providers. Of these 4 references that I was able to get. So it seems like there are providers out there who are doing it for pain control.
Yeah, I mean, you can do whatever you think is right. I guess my thought is just that, we're dealing with powerful pain relievers and anti-inflammatories, which are not without their own, side effects or potential
Right.
side effects. And if you're not getting the effect that you want, my thought has always been to reevaluate and, kind of delve a little bit deeper and see why is it that it's not, it's not doing what I expect. If I believe that my technique was good and everything else. So I would be a little bit hesitant to kind of follow that, um, that kind of approach where after 4 weeks I'll do another one. But
Okay.
yeah, I mean, I don't know if that's just tradition speaking or, personal preference. Any other points anyone wants to bring up or discuss? No? Okay. Well,
Okay.
um, again, great job.
Thank you.
Yeah, maybe this is something we can look into at least for our diabetic patients who we still need to provide some pain relief for.
Okay. Thank you.
Great job,
Good job,
Anusha.
Anusha.
Thanks.
Thank you.